these are the stages of sleep, and we know that this is disturbed in Parkinson's. So if you look along the top, helpfully in really pale blue, so it's barely legible, is hours of sleep. That's what it says just above that dark blue line. It's got a series of numbers, 0 to 8. So when we fall asleep, which is that first darker blue thick line dropping right the way to the bottom, you can see we go into fall through stage 1, stage 2, and stage 3 sleep really very quickly. So we go into sort of deep sleep to start with in the first hour or so of sleep. And then we cycle through sleep through the night, coming back up to have REM sleep. That's rapid eye movement sleep, when we dream, and that's the horizontal black bars. And you can see that in the first 3 hours of sleep, there isn't much of that dream sleep. That becomes much more of a feature of our sleep after the first 3 hours, and the amount of deep sleep is less in the as we approach waking. The deep sleep is what we need to wake up feeling refreshed. So if you wake up in the morning and you're feeling unrefreshed, the chances are that you haven't had much of that deep sleep overnight. Even if your overall night was quite short, you could still feel refreshed if you've had enough deep sleep. And likewise, if you've had a long night's sleep, but actually a lot of it was disturbed with lots of arousals, lots of dreaming, then you might wake up feeling completely unrefreshed because you haven't had enough deep sleep. These are all the reasons that sleep is disturbed in Parkinson's, and as you can see, it's a winning combination of symptoms, and it can take some teasing out to work out exactly what it is that's contributing to somebody with Parkinson's not sleeping well. So the first one, of course, is motor symptoms, and this is in some ways the easiest one to think about. So for most people, as you all know, in Parkinson's, there's some slowness and some stiffness that's associated with not enough dopamine in the system. You replace the dopamine, and that slowness and stiffness and tremor, hopefully, would improve. The tremor will improve anyway by being asleep. You don't have tremor when you're asleep. And for most people, you're taking your dopamine replacement on 3 times a day, 4 times a day, 5 times a day, levodopa tablets, with or without a long-acting dopamine agonist, which should give you some 24-hour cover. But on the whole, most of your dopamine replacement is in the waking day. And you may take a long-acting controlled release or modified release levodopa tablet when you go to bed. Most levodopa tablets are sort of in and out of the system between 3 and 4 hours. The long-acting ones might give you, 4 to 5 hours, but on the whole, it's sort of marginal in truth. So whatever dopamine you're taking, unless you're on a long-acting overnight, it's going to be out of the system, assuming you can go to bed at 10, 11-ish, by 2, 3 o'clock in the morning. So it could well be that you're waking up overnight because you're uncomfortable, because you've got stiffness returning in the shoulders, or you difficulty moving, or you're getting off-period dystonia, where the muscles are cramping. So anything like that, which just says there's not enough dopamine in the system because actually you haven't taken a tablet since 8 p.m. the night before, or 6 p.m. the night before. So that's quite common, and that's quite easy to tease out and sort out. And the way that I would sort that out, albeit not a perfect solution, would be to suggest to people that you take a Madapar dispersible when you first wake up. So if you've got repeated awakenings through the night, if you take a Madapar dispersible the first time you wake up, that will hopefully allow you to get back to sleep with greater comfort, and that can be very effective. Where to next? So the next one is autonomic dysfunction. And the autonomic nervous system is the bit of the nervous system which just functions and sorts out all our bodily functions for us. And as we've been discussing already, it goes a bit awry in Parkinson's. So this is the bit of the nervous system which controls our bowels, our bladder, blood pressure, sweating, and because the autonomic nerves are affected in Parkinson's, any of those things can be affected, and of course impact on sleep. So people could wake up with night sweats, or it could be that you're needing to get up to pee a lot overnight, So anything like that might impact on sleep. The reason for my hesitation was I was just wondering there whether breathing might be one of those reasons. So of course breathing is another automatic function, and we know that often people can wake in the night feeling breathless, and it might be because they've got some sleep apnea, which is certainly worth thinking about, or it might be that they're waking up breathless related to anxiety that you're experiencing with the off state, because that can be quite common. But I think that there also is a sort of a breathlessness sometimes that comes with being off or in Parkinson's, which can be dopa responsive. The next one is iatrogenic insult. Iatrogenic means, related to a drug or something else that you've taken. And some drugs that we use in Parkinson's can affect the sleep. The most common one would be amantadine. So we use amantadine to treat dyskinesias. But if you're on amantadine, hopefully you're only taking it first thing in the morning and at maybe 2 p.m. and not later than that, because we know it can impact on sleep. So that would be something, again, that's quite generally easy to resolve. I'm going to skip the yellow box and come back to it. The next one is sleep disorders. So this means things that affect other people affect all of us, not necessarily related to Parkinson's. So I've already mentioned sleep apnea, obstructive sleep apnea related to snoring when the breathing becomes affected. It pauses for a short while and you can rouse. That of course is quite easily treated with a CPAP mask, where you wear a mask overnight, which just help keep the airways open, and that can be very effective. And other problems with falling asleep and staying asleep, which can affect other people. So those other sleep disorders can occur in Parkinson's, and unfortunately having Parkinson's doesn't protect you from having anything else, as we've discussed before. So I'm going to lump together the blue box and the yellow box, which is in Parkinson's, the bit of the brain that controls our sleep-wake cycle or our circadian rhythm is affected. And so we do end up with what's called circadian disorder, where the brain doesn't cycle through those normal sleep cycles, and can get into a bit of a muddle with triggering sleep. If you think about that sort of sleep pattern in Parkinson's, in all of us, when we go to sleep, we call that sleep initiation, and then staying asleep we call sleep maintenance. And often in Parkinson's, people can get to sleep okay, so the sleep initiation bit is fine. It's the staying asleep that's the problem. And ordinarily, when we go to sleep, we produce a surge of a hormone called melatonin. And this is a sort of a sleep hormone, and it's related to the bit of the brain that's driving the circadian rhythm. So as we get older, and with Parkinson's, that melatonin surge is diminished. So you're not producing enough melatonin, and melatonin is maintained at a high level through sleep and then drops off before we wake, and that then helps us rouse for waking. So if you don't have enough melatonin on board, then that can affect your sleep maintenance. So even though there's no problem with movement overnight, and you're not needing to pee, and you're not taking amantadine, and there's no reason why you should be waking up, people can still be waking every 90 minutes through the night, and that is probably because of a problem with maintaining the sleep cycle. So actually, in order to treat that, you can replace melatonin. You can take it in tablet form, and in actual fact, in the States, it's available over the counter for treating. People would use it if to avoid jet lag, for example, or if they're shift workers, to try and get their sleep back into a decent pattern.
Camille, there seem to be so many reasons for sleep problems. One night I'm over-medicated, and the next night I feel as though I'm under-medicated. It seems terribly difficult to get to the bottom of what is actually causing the problem. What would you recommend?
Well, we haven't talked on there about REM sleep behaviour disorder, which is another I don't know where that would fit actually in there, the sleep disorders part. So in Parkinson's, ordinarily what we do when we dream is we parallel paralyze ourselves so that we're not acting out our dreams. And that paralysis bit of the mechanism again goes a bit awry in Parkinson's, so people aren't paralyzing themselves in the same way when they're dreaming, which is why you're sort of thrashing out and acting out your dreams, which is of course very troublesome for the bed partner potentially. No, you're right, it is difficult to tease out, and therefore, and the only way to do it is by getting a good history, by asking people, what if you do have to get up at night to pee, are you slower, how's your walking? And if people are very slow and stiff overnight, then that's an easy win, because you can, as I said, it's very easy to give a bit more dopamine replacement, or to make sure that's optimized overnight. But if people's mobility is fine, then that's not the reason. So sometimes treating the bladder separately can be very helpful. I mean, I don't know what's acceptable in terms of how many times you have to get up to pee before it starts to become an issue for sleep. I remember speaking to a bladder specialist who said, or maybe it was a sleep specialist, I forget, who said, well, actually it's 0. Yeah, the idea is not to be disturbed at all. And there are plenty of people who are getting up once or twice. There's also quite a lot of people getting up 3, 4, 5 times a night. I mean, I can't imagine getting up 3, 4, 5 times a night to empty your bladder. And if every time you're getting up overnight to pee, you're needing assistance to get in and out of bed, very quickly that becomes hugely impactful for everybody. As I keep saying to people, what you don't want is a sleep deprived spouse, for sure.
And that's exactly the problem, isn't it?
So I think it's really important to tease out, what is the problem here? Is it a movement problem? Is it a sleep disorder problem? Is it a breathing problem? Is it REM sleep behavior disorder, which might not be waking you up with Parkinson's, but it might be waking your bed partner? Is it bladder? And I've forgotten the other one, anxiety. So anxiety is obviously all mental health issues generally. Anxiety and low mood will affect anyone's sleep, and of course both of those things are more common in Parkinson's, so it's really important to get on top of those. And if anxiety is driving sleep problems, where people are waking and their room, gosh, we've all done it, you wake up because you're stressed about something, and you're ruminating on something, and you can't get these thoughts out of your head, and you're anxious, so it's difficult to get back to sleep. It's important to understand that. So we use the Parkinson's disease sleep scale actually quite often, because it just breaks down the various aspects of sleep. Although I have to say, I don't think it includes an item that gets a handle on anxiety, but it covers most of the other things that can impact on sleep. So I generally send out a sleep hygiene booklet, for the general population, which is probably about the same length. And this seems to have pretty much similar stuff in it, but much more tailored to Parkinson's.
Okay.
So this is going to be my new booklet of choice. But as well as covering off everything that I've talked about, it also talks about sleep, for everyone. Mm-hmm. So avoid caffeine, obviously, in the later afternoon and evening. Make sure you get enough exercise. Try and get some daylight exposure, because daylight will contribute to melatonin production. And so, particularly in lockdown and people not going out, and there are people who've not left the house much over lockdown, so they're not going to be getting daylight exposure, which will affect their sleep. So these are simple sort of things. Avoiding screens, with the blue light business that keeps us awake, again, that affects your melatonin production. So there are things that we all ought to be doing to maintain a good sleep hygiene, which will then help with sleep overnight as well.
A question for you, Camille. How does night and shift working affect sleep cycles and medication with Parkinson's?
That's a winning combination. So I think, oh gosh, I mean, it can affect it. And for some people, for sure, it can be a reason to talk with your employers about not doing the shift work. But shift work will mess up assuming we're talking about night shifts, or late night, early morning sort of things. That will mess up most people's sleep cycle, and having Parkinson's can make that more difficult, which is why it might precipitate a conversation with an employer. But if it's manageable, and I do have some patients who are managing their shifts, but what it does impact on is the whole medication regime. so their medication regime is just varied from waking, whether that's 3 o'clock in the morning or 10 o'clock in the morning, depending what shifts they're on at that time. And you can take, assuming that your shifts are a block, as opposed to, one shift one night and then 2 nights later it's a different one. But assuming it's a block, you could, if it were an issue, you could take your melatonin an hour before you want to go to sleep, whenever that is.
I guess it's the same problem when you cross the date line when you're travelling abroad.
No, exactly. At some point, you just switch to, right, I've now started my new day.
Another question: is it more important to get quality sleep rather than to sleep for as long as possible?
I think you're right. I think the overall time in bed doing some sort of sleep is not so relevant as the time of restorative sleep. And I think if you wake up feeling refreshed, then that would be indicative of you having had enough sleep. But there is a growing literature around sleep and its importance for all of our mental well-being and preserving cognition, thinking and memory, and future mental well-being is also dependent on the amount of sleep that we have. And the thinking is that it's during sleep that toxins are cleared from the brain. There's a particular system that opens up called the glymphatics, and that as our brains are less active overnight, these channels open up, and this is what takes away, the alpha-synuclein or the amyloid or whatever it is that's building up. So and that would happen more during deep sleep. A sleep disorder or anything affecting the sleep, this can be investigated through sleep laboratories, where they'll wire you up to an EEG machine and then look at your body movements and these sorts of things, and get a much better idea of which stages of sleep you're in.
If you can possibly remember, and given that it's the middle of the night, wouldn't simply just writing down what time you woke up and what time you went to bed do the same thing?
It wouldn't tell you what stage of sleep you were in before you woke up.
Okay, we've got quite a few questions coming in now, so thank you.
Kevin's got his hand up.
Kevin's got his hand up, but Anne asked a question in the Q&A box first, so I'll go to Anne's question first. Is waking from sleep with hot legs and a burning sensation in the lower legs likely to be related to Parkinson's?
Yeah, that could reflect what we were talking about, the temperature sensation problem also being affected in Parkinson's, and blood vessels becoming dilated around the skin, and presumably in bed the legs are going to be warmer, so there might be some dilatation of the blood vessels, the capillaries in the skin, causing the legs to feel hot, as well as the general temperature control, which can go awry.
Is there any reason that it happens at night particularly, or is it just...
Only because I'm just thinking of a warm environment for duvets being a warm environment for the legs. I don't know.
Right. Is it advisable to take sleeping tablets if they have been taken for a while? Can this affect or assist the deep sleep?
So sleeping tablets generally are short-acting sedatives, so they can help tip somebody into sleep. So on the whole, as I said, people with Parkinson's tend to get to sleep okay, but that is not always the case. So sometimes people can have a sleep initiation problem, and then taking a sleeping tablet to get to sleep in the first place can be very helpful. So the two that we would generally use are zopiclone or zolpidem, and they can be very effective. I think zopiclone, particularly if they need to be used long term, then I don't think there's. I mean, of course, with any of these sorts of tablets being used long term, people can be cautious and nervous about it. But I think it's more important that you get to sleep, and a low dose, even half of the standard dose of zopiclone or zolpidem, can be very effective.
Yes, because that was actually the question, was what maximum minimum doses of melatonin would you recommend as well? As another question from Helga. Yeah, so melatonin, in the UK, the brand that is available and prescribable that doesn't cost a fortune is
probably shouldn't mention the brand. Anyway, it's a controlled release, and it comes in one dose, which is 2 milligrams. So what I recommend is that people start on 2 milligrams, and that expecting nothing to happen, and then to increase by 2 milligrams a fortnight. And most people achieve a better night's sleep on somewhere between 4 and 8 milligrams. But it might be that you need as high as 12 or 16 milligrams. So keep bumping the dose up by 2 milligrams a fortnight until you feel that sleep has improved.
Ellie's asked a question, which is, how do I combat dystonia? Is there a drug which is effective?
Yeah, so I'm assuming that this is dystonia overnight in sleep. So to me, this would indicate an off state. And so my thoughts would be to, first of all, try and improve the dopamine replacement overnight.
Right.
Assuming that's what's meant, Helene, but that you're meaning an overnight dystonia as opposed to daytime dystonia.
Okay. Right. Kevin has typed his thank you, Kevin. Sorry we couldn't hear you properly. He says, I'm waking every 2 hours approximately, needing a pee when I find it very difficult to get up quickly enough. Often the urgency to pee is false. Is there any way of suppressing this?
Yeah, so that's interesting. So I would ask, are you sure that it is the urge to pee that is waking you up, and that you're not waking up and thinking, oh, I'm awake, I might as well go for a pee? It doesn't sound like that's the case, but it's often worth teasing that out. In terms of the logistics, obviously if mobility is affected overnight and you're having difficulty getting to the loo, then having a commode, or if you're a chap, you're even luckier because you can use a bottle. So that can be quite helpful. The fact that you're telling me that you're having difficulty getting to the toilet on time does suggest to me, if the movement is worse overnight than it is during the day, and the bladder's a bit irritant, then it could be that there's not enough dopamine on board overnight, because we know that will contribute towards this bladder being irritable. So that might settle down with adjustments of the Parkinson's medications, or the bladder needs treating separately. And again, there's ways of thinking about the bladder, particularly in chaps, because you've got prostate. So it's important to tease out whether it's a prostate problem affecting the bladder or whether it's a Parkinson's problem affecting the bladder. And then each of those things can be managed separately. Some people do have exactly what you're describing, but they're peeing out litres overnight. You know, it's almost like the bladder gets active overnight and they're actually not peeing out that much during the day. So again, we can manipulate the way the kidneys function so that you're producing less urine overnight if that's a problem. So we would treat all of these things differently.
Does acting out your dreams indicate potential onset of dementia?
So the easy answer is no. Yes, I think I'll stick with the no. I'll expand on that.
Okay, that's fine.
So the acting out dreams, REM sleep behaviour disorder, occurs outside the setting of Parkinson's, but generally is indicative of possible Parkinson's, more likely probable Parkinson's or Parkinson's type syndrome in the future. So we now understand quite a lot about REM sleep behaviour disorder, acting out dreams, and it does seem to be linked to alpha-synuclein accumulating in the brain. And alpha-synuclein is the protein which is found in Lewy bodies, which is the hallmark of Parkinson's disease. So people who have REM sleep behaviour disorder are likely at some point in their lives to develop a Parkinson's syndrome or an alpha-synuclein syndrome. And there are three main syndromes, conditions, diseases in which alpha-synuclein accumulates in the brain. One is Parkinson's disease, one is dementia with Lewy bodies, and one is MSA, multiple system atrophy. So it could be that it's an early indicator of one of those conditions developing, and of course it is then almost by definition relatively common in Parkinson's, but it might have predated the Parkinson's by 10 years, 15 years or more. So this is interesting from several points of view. First of all, understanding about how Parkinson's is affecting the brain and how long people might have been living with it for before it becomes apparent in the movement symptoms, which eventually lead to the diagnosis. But also thinking with one of my other hats on, which is about protecting nerve cells from dying in Parkinson's, and what can we do to prevent Parkinson's progressing. You'll understand from what I've said that there are people who we think have got quite a high chance of developing Parkinson's in the future, where it might be possible, if we did have a treatment that stopped Parkinson's from progressing, that we've got a sort of an almost pre-Parkinson's condition that we've been able to identify. And there are research groups around the world, Michelle Hugh in Oxford and Ron Postuma, I think in Canada, who have groups of people with REM sleep behaviour disorder without Parkinson's or any other condition, following them up and seeing if we can understand more about what causes Parkinson's or how it might become manifest.
Okay. Thank you, Camille, for giving up your time to talk to us.